I wouldn't miss the opportunity. Am I good to go?
So Dr. Tobolsi is there. Oh, yes, you're good to go. Yes.
Okay, so it's my great pleasure and honor to introduce my friend and colleague, Elias Tobolsi, who is an extraordinary academician and artist. Elias is the head of the Department of Pediatric Ophthalmology and director of the Center for Genetic Eye Disease at the Cleveland Eye Clinic. And he's professor of ophthalmology at the same institute. He has so many roles that I won't go through all of them, but just to give you an idea, he's vice chairman for education at the Cole Eye Institute and director of the Center for Graduate Medical Education at the Cleveland Eye Clinic. He's also executive vice president and past president of the International Society of for Genetic Eye Disease and Retinoblastoma. And he's been editor-in-chief of the Ophthalmic Genetics Journal since 1992. He's written over 450 articles and chapters, and he has a seminal book. If you don't have it, it's called Genetic Diseases of the Eye, which is available. He's had so many named lectures and awards that because of time, I won't go through it. But I think interestingly, in 2019, he was recipient of the Parker J. Palmer Courage to Lead Award, which is a testimony to his educator role and his mentorship throughout his career. In addition to that, he's a normal guy, which is hard to believe. He's a fantastic dad and husband. He has the most incredible wife, and he's a wonderful artist. I don't know if he's going to show some of his paintings, but it's a real pleasure to have him spend the day with us. And Elias, I thank you for making the time. Thank you for dealing with COVID. And this is the 2020 lecture, but better late than never. So I would give you the warmest hug, but in the meantime, it's a real pleasure to have you with us.
Thanks, to you. I'm delighted to be here not in body, but certainly in presence, and I'm deeply honored. And my latest news is you said I'm a wonderful dad and husband, but now I'm a grandfather.
Oh,
So 2 weeks ago, my grandson Malik was born. And
congratulations!
he's doing great, and mom's doing great. We're very lucky. My son Nadim and his wife Kirsten, they live just 5 minutes away. So we've been able to see the baby. And last night I held the baby for the first time. So it's those of us who are pediatric ophthalmologists would everybody, actually, I shouldn't say only those of us, but who are pediatric ophthalmologists would know what I'm talking about if they've held a baby in their arms. So especially if it's your own,
if it's yours, yeah.
So that's amazing.
We look forward to your talk.
Thank you. I'm gonna share my screen here. I hope everything works well. And I modified the title a little bit because there's so much to cover in retinal dystrophies, and I thought I would narrow it down to the childhood retinal dystrophies. But I think a lot of what I'm going to talk about does apply to adult onset retinal dystrophies. So these are my disclosures, and I really thank you for inviting me. Amandeep, can we do the questions, please?
Yep, so I've got the first poll up here. I'll give the audience maybe 15 seconds or so to go over this. Me personally, I feel like I'm back at the OCAP exam right now. So I'm going to give another 5 seconds or so, and I'll share the results of the first one here. There you go.
Okay. Wow. Wonderful. That is absolutely true. And we can do the next question. So I'm doing the 3 questions in the beginning, so we have an idea of where people fall, and just get you up and going with the presentation.
The second one should be up now.
It's up. Thank you. We see it.
A bit more of a mix here. So I think you've got the audience a bit stumped here. Let's end the poll here.
Okay, so we're going to talk a little bit more in detail about CRB1 later, but the answer here, and I can understand this is a little confusing question, but the answer is C, profound vision loss since birth, because we see a lot of patients with CRB1 mutations who have preserved vision, better vision than you expect, onset or detection at least a little bit later in life, etc. Next question.
Yeah. You know, this is great. Our senior residents have their final exam today, the Royal College exam. So this is a great review for anyone who's writing that exam. And I'll give that another couple seconds and then we'll share the results. So can you see that there, Dr. Trabulsi? Is it, oh, did we lose him? Oh, Dr. Trabulsi, you're muted.
Yeah, I think it must have been my internet connection, but we're back. So it was North Carolina macular dystrophy, actually. That was the correct answer, which is caused by a totally different gene. Okay, we can go. Let me go back to sharing my screen. Okay. So we've really come a long way in conquering inherited retinal disease through the efforts of a lot of groups, clinicians, basic scientists, industry, patients, funding agencies. And that also is in the midst of better organization of professional organization, better education of patients. Technology has been amazingly helpful, and the explosion in medical and scientific knowledge, especially in genetics, as well as the provision of resources and financing, a lot of it from industry for that to happen. So I hope that at the end of this talk, I'll be able to clarify a little bit the classification of retinal dystrophies in children. And I want to emphasize the importance of the clinical exam and paying attention to the clues that are involved in reaching a precise diagnosis in the individual patient. I will give examples of some cases. I hope we can go over all of them. It depends on the time. And this is not a lecture on gene therapy for inherited retinal diseases. I will be very brief when I discuss the current treatments. I watched Elise's presentation on RPE65 treatment, and I want to congratulate you for having that repository of lectures that your faculty give and made available to the world to look at them. So thanks for that. Let's start by talking about a very famous and amazing man who in the 1870s describe what we now recognize or name Leber congenital amaurosis. But he was not only the first one to describe the congenital amaurosis that now carries his name. In 1916, many years later, he was also the first to appreciate that the phenotype of congenital amaurosis was heterogeneous and that it blended with that of what we now call early childhood onset severe retinal degenerations. The other person who also recognized that is one of my favorite people and heroes, Jules François from Ghent in Belgium. And in 1957, in his book, L'hérédité en ophtalmologie, he writes that in exceptional cases, pigmentary degeneration of the retina may set in very early, before the age of 7, and lead to very early total blindness. However, he defined that it did not necessarily have to be there at birth, but can be up to the age of 7 years. And I think he was really defining what we now recognize as early onset childhood retinal dystrophy. There's no doubt that the earlier the onset of the disease, the more severe in general it is, with some exceptions, of course. And the later it has its onset, probably the less severe and the slower in general. It's a continuum, actually, and eventually these patients' continuum of retinal disease merges with that that we have called traditionally retinitis pigmentosa. So early childhood retinal dystrophies, as we now call them, are a collection of clinically and genetically heterogeneous diseases. As Francois and Laber recognized, the clinical onset is usually in the first few years of life, and the manifestations are variable and may or may not be detected at birth. And we put in them vision loss, nystagmus, light sensitivity, night blindness, ophthalmoscopic changes, and ERG abnormalities. I show you here a fundus photograph of a patient with Goldman-Favre disease. You can see the cystic changes, these subretinal fibrotic-like changes in some of that pigment clumping that is so characteristic of this condition that's due to mutations in a gene called NR2E3. I tried to put together a list of what would fall under the early onset childhood retinal dystrophies. I'm sure I missed some, and there's always a case report of this and a case report of that has a very early onset. But in general, I think I've probably included most of them, and I divided them as we do it for all retinal dystrophies, those that occur or that have manifestations only in the eye, and those that occur in the setting of a systemic disease, or that have been referred to as syndromic, although that word is not appropriate in my mind. And you can read the list here. I'm not going to go over it. We've recognized the genetic heterogeneity in many of these, especially Leber congenital amaurosis, congenital stretching night blindness, achromatopsia, Bardet-Biedl syndromes, the Usher syndromes, many different genes that cause overlapping phenotypes with major characteristics that are there in common. We've also realized, and this is a paper from about 10, 11 years ago, where a number of us put patients together, and we're just trying to show that you can carry a mutation in one of these genes that classically was attributed to cause Leber congenital amaurosis, and yet have vision that is not light perception or count fingers, but could be as good as 20/40. And you can see, of course, much less or many less patients who have that, but definitely a spectrum in the severity of visual acuity loss. Our general approach is to secure a precise molecular diagnosis in all patients. And that is an unshakable goal at this point in time. And some patients either refuse, are not interested, or are unable to qualify for a genetic test, which has become less and less of a problem in more recent years. But we need to know, and they need to know, what the underlying molecular diagnosis is. Now, this does not mean that we should not try our very best to secure the best clinical diagnosis, and that is definitely the major part of the visit with these patients. Otherwise, you might as well just take a blood sample, get some DNA, and run a panel, and then see where it falls. So what I'm going to show you is that we have 3 steps in this process. The first one is the history. The second one is the physical exam and the clinical test. And the third one is the molecular testing. That's basically it, just like we do in any other field of medicine. So the appropriate questions in my mind are to see when it starts. So we ask them about age of onset. We draw a pedigree. That's really critical. We look very carefully and we ask the appropriate questions to try to detect systemic abnormalities. And we will talk about the ciliopathies in just a minute. Then we ask these patients whether they prefer dim lights or whether they prefer brighter lights. And my favorite question to ask them to detect problems with dark adaptation, because that's really what we want to hear about. It's not whether they can, they can drive at night or whether they see, but because that's what comes to their mind as you're inquiring. You ask them, if you move from a room that has normal lighting to a room that is very, very dim, but not pitch black, do you find major difficulty finding your way around? And if you are with another person, can they find their way around the room and you cannot? And you can give them the example of going to the movie theater and the movie started and their companion can go and find their chair and they're standing there waiting to dark adapt. That is a good question for nyctalopia. The other thing is when we get their field of vision test, we want to determine whether it's peripheral loss, central loss, or a combination of the two, because each one of these questions will lead to a category. Patients who are very light sensitive generally would have cone dysfunction. Those who have trouble with dim lights and night blindness have rod dysfunction, and those with peripheral vision loss have generalized kind of dystrophies, and those with the central loss have macular dystrophy. So you see the arbitrary, in a way, classification of this group of disorders that over the decades has led to some confusion. It's getting better now because we know the genes. All I'm going to say about the ciliopathies is that they've been recognized now as the major category of disorders where retinal dystrophies are present in the context of other systemic findings. And you can see how a multitude of systems is involved, all the way from the skeleton to the ear to the kidney. They can be obese, etc. And the bottom is a list of some of them. It's much larger now. Alain Dolphus gave me this slide, I don't know, maybe 10, 15 years ago. So it's not a recent one. Number 2 is a physical exam. We have to look for specific objective findings. And we get these ancillary tests. I don't know what I would do without OCT, fundus autofluorescence, and certainly ERG continues to be very helpful. But those have made a huge difference in our ability to make a good clinical diagnosis in these patients. And sometimes you just look at the fundus and you can tell what the patient has. I'm sure you all recognize that this is the fundus of a patient with choroideremia, and indeed, that's what it is. And evidently, you don't want to just look at the retina. You don't aim directly at the pupil with your indirect ophthalmoscope. You sit back and you look at the patient as a whole, because many times you can get clues for what they have because they're wearing a hearing aid, or they have a scar on the side of their hand where an extra digit has been put together, or they're very sick and they have renal failure or something, or diabetes, etc. So all these are very important questions. Sometimes you can just look at the fundus again and you can tell immediately what the diagnosis is. This is fundus albipunctatus, of course. You've recognized it. You look at this patient and you can tell what the gene is. It's X-linked juvenile retinoschisis, and the mutation is in RS1. Here's a patient with a recessive bestrophinopathy, and that, multiple lesions. What you see here in the right eye, that's a scar from choroidal neovascularization, which can occur in some of these patients. We've seen a couple over the years, and the OCT is quite characteristic. And this is our friend Stargardt disease, the great mimicker, the most common of the retinal dystrophies, with a bullseye maculopathy, and then you get a fundus autofluorescence, and then you can see more of the flecks. These are the patients who go to see sometimes the eye doctor for the first time, and their vision is decreasing. We're talking about children here. Their vision is decreasing, but they look at the fundus and they don't see anything. But indeed, if we did fundus autofluorescence, or in the old days, fluorescein angiography, we can detect the presence of these flecks and the diffuse storage of lipofuscin in the retinal pigment epithelium that blocks the fluorescence on angiography. We don't do that anymore. All the cases, the great majority of cases are autosomal recessive and result from mutations in a gene called ABCA4. There are some dominant cases from mutations in a gene called PROM1. This is the younger sister of a patient with Stargardt disease, and she's totally asymptomatic. We just took a fundus photograph on her, and you can tell that she's unfortunately affected. Just a sidebar here. When do we test children for genetic mutations? How do we tell them, how do we tell the parents that their child has a retinal dystrophy? Very difficult to relay these types of diagnosis, as you might imagine, and especially in ophthalmology. We're not used to delivering bad news, but it could be very difficult. And at the same time, we could do it in an inappropriate way. And I've put my foot in my mouth a few times and not paying attention how I tell the parents. And there was one incident where the children, two boys with X-linked RP, were sitting there with their mom, and the little one just burst in crying when I was telling her, not paying attention that they were there. I just didn't pay attention. And he remembered, he knew that his grandfather had the same thing and he went blind. So just keep that in mind when you talk to these patients. Here's another patient here with quite a characteristic fundus finding on OCT, and this patient has achromatopsia. Finally, I think this is my last characteristic picture, is one taken from this paper by McLaren et al. On RPE 65. I don't have an example, but there is no autofluorescence because there's no accumulation of lipofuscin there. There are some special diagnostic considerations or situations or things you need to think about. If light sensitivity is the main symptom, think achromatopsia, think Alstrom syndrome, think LCA with Gucci 2D mutations. When there is retina changes, when there are retinal changes, but visual acuity is good, think CEP290, think CRB1. And finally, we've come to realize in the last decade or so that there are many patients with ciliopathies where there is a retina problem, there is a retinal dystrophy, but the systemic findings are very mild or absent. And that includes patients with Usher syndrome and Bardet-Biedl syndrome, and early cases with neuronal ceroid lipofuscinosis, where patients can present with severe or rapidly progressive vision loss and have not developed their terrible neurological deficits yet, but the great majority will get them shortly thereafter. However, there are some who remain asymptomatic from a neurological perspective into adulthood, and those cases have been described. And we get to the last step, which is obtaining the molecular genetic testing. I know many of you have seen this graph from RetNet. I think it's plateauing. I think we've probably come close to identifying all the genes that are responsible for retinal dystrophies. There's still some that have been mapped but have not been cloned. We will get there. The great majority are those involved in different part of the photoreceptor physiology, if you will, and structure, including phototransduction, cascade proteins, visual cycle proteins. There are some that are rarely in the RPE, and ciliary transport is a big one, because those proteins that are responsible for the structure or the transport across the cilium are those that cause the majority of syndromic RP. And there are others: synaptic transport, cell development, etc., etc. And this is how people approached, or scientists approached, the discovery of what causes different types of retinal dystrophy by targeting initially the genes that code for these types of proteins involved in vision. We don't just get the genetic testing in the vacuum, and I know I'm preaching to a crowd here that understands this very well and is convinced about it, but it's really important to get the phenotype correct. It's very important to get the pre-test counseling, preferably by a genetic counselor. As good as we may be as physicians, even those of us who are clinical geneticists, we will not do the same good job as the genetic counselors. They will do a better job than we do. Financial considerations, as I said, have not been very bad recently in the US, at least. They vary from country to country. I'm not very familiar with how you are in Toronto and Canada. The interpretation of the findings is critical. The labs, the commercial labs, have been better at interpreting sequence variations, and they provide an explanation for that in the typewritten report. But that has also evolved over the years, and they've gotten better. And finally, we have to be able to deliver the results of the test to the patient and the family. So just to take a little bit broader view, more of an epidemiologic look at inherited retinal dystrophies, Ed Stone and colleagues looked at 1,000 consecutive families with inherited retinal diseases. Now, this is a combination of adults. I don't know how many children were in that group. They do not state it in the paper, but they found that Stargardt disease is the most common of all, accounting for 17% of cases, and 13 genes account for the majority of cases. After that, every one of the others account for less than 1%. I wanted to see how, what genes I was seeing in my clinic, and this is between 2012 and 2017, I had 119 children with retinal dystrophies go through my retinal dystrophy clinic. And we were able to get molecular testing in 99 cases. And when I put them in different categories, you see that those who fall into labor congenital amaurosis were the most common, followed by Stargardt disease. And you can read the list going down on that slide here. And a total of 30 genes in these children, ABCA4, RS1, blue cone monochromacy, Alstrom, and CRB1 accounted for 50% of cases, and the rest for either 1 or 2 cases or so. And it was possible to have a molecular diagnosis in 82.5% of cases. And although I had given some patients a diagnosis of LCA, it turns out that a third of those patients had mutations in actually the Alstrom syndrome gene. So that is one of the great mimickers of LCA, because it's a syndromic form of retinal dystrophy with problems with the heart and other systems. Now, if I take the patients with LCA and mutations in genes that have been classically associated with LCA, CRB1 leads the group. And I have not had patients with RPE 65. I've only had 1 patient, but actually 3 patients, but they were not in that time frame that I selected for this particular study. So let's talk a little bit about CRB1. That made me more interested in that gene, and how common is it among the inherited retinal dystrophies? If we look at Stone's paper, CRB1 is number 6. Now we're talking about adults and some children. If we look at the series from the UK, it's at number 10. If you take the full cohort, and goes up to number 9 if you look at children. So it's up there. In the UK, RPE 65 was more common, but that's about it for LCA related genes. You can see that Retinoschisis and Best disease are ahead of it, and so is X-linked RP with RPGR mutation, and some of the other ones, Achromatopsia with CNGB3. And I think this is what drives the clinical trials, because they want to invest in disorders that are more prevalent. If we look at the literature, again, from a multitude of countries, CRB1 is up there. So it's just bring it up to your attention as being one of the more common genes, and one that may not be diagnosed very early in life, and in which vision may not be terribly affected. In Chile, 13%, second only to ABCA4. I'll show you a case here, a 5-year-old who had decreased vision, light sensitivity, difficulty seeing in dim light. He was treated for esotropia and amblyopia before the diagnosis was made. No systemic abnormalities. These are some of the pictures. They're, of course, the greenish tinge is because this is an Optos pictures and the filters are not correct. So you do not have that greenish tinge in real life, but you can see the maculopathy there, and some of the preservation of the para-arteriolar RPE, which is quite common in these patients. And on OCT, there is some fluid in the retina of both eyes. That's actually also fairly common in patients with CRB1 mutations. And you can also see, as indicated by the arrow, that the retina is thick and disorganized, and that's extremely characteristic of CRB1. You can make that diagnosis based on an OCT. In my mind, there's no other condition that looks like it on OCT. And when we did the genetic testing, this patient was compound heterozygous for mutations in CRB1 that segregated properly from the family. from the parents. We treated him with dorzolamide, and there was a good response. You can see it there 3 months later, much improvement and some improvement in vision. And this has been reported now in a number of papers. I always treat with dorzolamide. I don't use Diamox for a variety of reasons, but that we're not going to go into. But anytime there's CME in any of these patients with inherited retinal dystrophies and in patients with retinoschisis, we put them on dorzolamide 3 times a day, not twice a day, but 3 times a day. And some of them we have a response, and some we don't have a response. I just, especially the retinoschisis patients, I keep them on it indefinitely until we can get gene therapy for them. Here's another slide showing the preservation of the para-arteriolar RPE that is quite evident, especially on fundus autofluorescence, because that's where the lipofuscin is. And another complications, if you will, of CRB1 retinopathy is this Coates-like response. So if you see that in an adult patient with quote unquote RP, that's one of the condition, that's one of the genes you need to think about. So let's go over a few cases. I'm looking at my watch here, 8:09. So we have about 21 minutes, maybe 20 minutes left. Here's a case, 3-year-old, night vision problems, vision fairly good in one eye, amblyopic in the other, was tested for LCA panel at the time. Now, some of these cases are a little bit older. Now we go straight to a retinal dystrophy panel in the great majority of patients. And surprisingly, the patient had a rhodopsin mutation. They generally do not cause a disease that is evident so early in life, but in this particular case, it did. And I know of other cases of course, that have shown up in very young people. So rhodopsin could cause a retinal dystrophy with clinical manifestations in early childhood. Here's another challenging case. This is I think he was 3 or 4 when we saw him the first time. This is how his fundus looked like, and his vision was 20/40. We thought, oh, you know what, this may be choroideremia. We checked his mother's eyes, they were normal. We tested him for CHM1, there were no mutations. Somebody said, oh, you know what, maybe it is gyrate atrophy, it's just some atypical form of gyrate atrophy. Serum amino acid quantitation was normal. And we put him initially in this category of early onset childhood retinal dystrophy with no specific diagnosis until we were able to get molecular testing with a panel, and I'll show you what that was in a minute. His vision deteriorated fairly quickly over a few years, and now he's in his teens, and I think he's like light perception or hand movement. And the panel showed that he has mutations in RDH12. There isn't a trial yet for gene therapy in RDH12 that I know of, but I know they're working on that in Philadelphia. Here, these are, I saw these 3 siblings, the 3 Amish siblings with neonatal onset of nystagmus, light sensitivity, and progressive loss of vision. Initially diagnosed them with Leber congenital amaurosis. They had this pigmentary retinopathy with macular involvement, and we know patients with LCA can have these macular types of lesions. What I didn't know when I saw them in clinic is that they were all wearing dentures and that their teeth had been pulled when they were around the age of 10. I discovered that later when I asked their mother, and she told me, and I asked the question after we knew that they actually had mutations in this gene, CNN M4 that causes retinal dystrophy with amylogenesis imperfecta or Jalili syndrome. This is not one of the kids. This is taken from another patient. So another part of the body that we need to look at carefully in patients with retinal dystrophies, just look at their teeth or ask them if they've had their teeth pulled. Sometimes the history really gives the diagnosis away. Here's a 22-year-old who had received the diagnosis of retinal dystrophy. She's had an ERG with reduction of responses, both of cones and rods. Her vision was 20/30. Somebody had done an MRI because they thought that maybe this was related to an optic nerve problem, and they were actually correct. In a minute I'll show you. And she had some color vision deficits. When I looked at her, I wasn't impressed that she had any retina problem. Her blood vessels were good. The optic nerves were really pale. And we started asking questions that people may not have asked her before, and she admitted that she'd had an overactive bladder and was slightly hard of hearing. And what was also in her chart was that she's had diabetes since she was 7 years of age. So that actually points to a diagnosis of Wolfram syndrome or DIDMOAD, diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. And indeed, she had 2 mutations in the Wolframin gene, which is recessive. Sometimes we just have to look at the pedigree and we can tell or we can guess what the diagnosis is. He's a 28-year-old who's night blind, good central vision. He's myopic, narrowed visual fields. So he has RP. So a man with RP and myopia, the first thing that comes to mind is X-linked RP. And indeed, this is not his pedigree, but when we drew the pedigree, we found affected males on the mother's side and some mildly affected carrier females. And he did have a mutation in the RPGR gene. You look at this picture, and I'm sorry, I'm going to skip quickly because I forgot to remove the question. So this patient has X-linked juvenile retinoschisis with a mutation in retinoschisin. And I wanted to show you the most dramatic example that I've seen. And that's the same patient I showed you before of response to topical carbonic anhydrase inhibitors, 3 months apart. I couldn't believe it, but here's the data. His brother, who's affected, has the same mutation, did not have a response. So I don't know why this brother has a response to the carbonic anhydrase inhibitors, to dorzolamide in this case, and why the brother did not. We looked at a series of these patients, and consistently, or in many of them, there was a reduction in central thickness on OCT, so a good response. And that has been also previously published by a number of individuals. Another case, this 7-year-old referred with the diagnosis of amblyopia, been patched, they tried atropine, they couldn't get his vision better than 20/65 in one eye and 20, maybe 30 or so in the other eye. Normal vision with, normal color vision with the Ishihara plates, good stereo, no nystagmus, no iris transillumination, kind of palish fundus that you can see here. The OCT, the fundus autofluorescence and the OCT are fairly normal, maybe some blunting of the foveal reflex. And so we might say, maybe this is albinism or a mild form of albinism. In fact, this is what we found on the ERG in that particular case, and you can tell that he has no B wave. And when we tested him, when we did the molecular testing, he did have a mutation in CACNA1F. So it's just a incomplete form of congenital stationary light blindness. We have to keep those in mind in patients with unexplained vision loss that can, not vision loss, but vision cannot be corrected completely. This is an adult here, 49-year-old, mild central loss since her 30s, previously started with AMD, diagnosed with AMD, started on vitamins, slowly decrease in vision over the years. And here, the ophthalmoscopy actually really gives it away. And those of us who have seen this before will recognize that especially the finding of drusen right at the optic nerve head is very characteristic of Malatia levantinase, or dominant radial drusen, and she indeed had the common EFEMP1 mutation. So last section here, if we talk a little bit about the prognosis and treatment of inherited retinal dystrophies in general. With rare exceptions, they are all progressive. Things are going to get worse over time for the majority of them. There are varying periods of apparent stability that may give the impression that the disease will only progress to a certain extent. And the older teaching was that, for example, in Stargardt disease, oh, your vision is going to get to 20/200, but it's not going to get worse. That doesn't hold anymore. Glucose monochromacy, same thing. We see these 50-year-olds, 60, 70-year-olds now with macular atrophic lesions. Same with achromatopsia. And certainly with choroideremia, in fact, it's the other way around. We thought that it was a rapidly progressive disease, but I would show you that the disease process does progress, but central vision does not drop until much later in life. The other thing that we need to keep in mind is that there's a multitude of mutations in each one of these genes, and the resulting phenotype varies quite a bit. It could be more severe and with early onset, or it could be less severe with much later onset. And this is quite characteristic of some of them, especially Stargardt disease, which is one of the more common ones. Here's a study that we did, a meta-analysis of the literature that one of your compatriots, Raza Kusa, did with us many years ago. We looked at 120 affected males with choroideremia, and you can see in the first 50 years of life, vision is visual acuity. Now, we're not talking about visual fields, that was not analyzed. Visual acuity is stable, and then you start, patients start losing vision after the age of 50. And we see that in other diseases, stability and then deterioration of central visual acuity as the cones and the fovea gets affected. To demonstrate also that ABCA4 phenotype depends on the mutation. This particular mutation here, the C5461-10 T to C, is associated with early onset disease, 12 plus minus 6 years. And here's a patient in the bottom. This is the same patient. She was 10, 46, and 49. And you can see how her vision went from 2100 at the age of 10 to hand movements and then light perception when she was 49. So you can get light perception vision in Stargardt disease in older adults, especially if you carry bad mutations. And it's beyond the scope of this lecture to talk about this particular genotype-phenotype correlation in Stargardt disease, but there definitely is one that's been recognized for at least a couple of decades. So finally, we come to what's made us all very, very excited in the last couple of decades here is the progress that has been made in gene therapy. And as I said, I'm not going to go in detail in it, but RPE 65 or Luxturna, the trade name for the quote unquote drug, because they refer to the virus vector carrying the normal gene as the drug, is available for treatments with I think reasonable outcomes and responses to treatment. CEP290 patients with CEP290 have been treated with antisense oligonucleotide intravitreal injections, and there's been a good response and at least one case with significant improvement in vision, to the extent that I think they stopped that trial, or they published it, the results early. Choroideremia treatment has also been very encouraging with some good initial results. And there are current trials for achromatopsia, RPGR, MERTIC, and you can see the list there. Some of them have made some progress and some have stalled. And there's a complete list that you can get on clinicaltrials.gov, and also on the APOS website. Actually, we have a group of ophthalmic genetics interested people who take turns in updating a list that is posted on the APOS website. One of the most exciting things I've read in the last couple of weeks is this paper that's still in preprint but available on the internet. And the group from Philadelphia has shown that at least 1 of 3 patients with Gucci 2D mutations have had an improvement in visual acuity by 0.3 log Mars. And this is an AAV mediated gene transfer or a replacement of Gucci 2D. So that is very exciting. I'm sure we're gonna hear more about it. So where are we in 2021? We know so much more about the disease course, but we know that with time, there's increasing loss of photoreceptors in the great majority of these disorders. Molecular diagnosis is definitely not only available, but widely available, at least in the US. Again, I can't talk. The unfortunate thing is that there are many parts of the world where this is still not available, and patients are a big disadvantage there. And the disparities that we talk about, that we want to overcome in our countries here, are even so much greater elsewhere. But it's available, and we can do it in babies. We can do it even prenatally. Some of us would prescribe supplements and UV protection. Low vision rehab, please do not forget it. It's so critically important for all the patients at any age, whether they're children or adults or older adults. They all definitely benefit from low vision rehabilitation. The work on neuroprotective agents, I'm not very familiar with it, I have to admit, but I know it has not been as effective as we would like it to be. Gene therapy has been the mainstay of progress, and some progress in stem cell therapy. I'm sure we're going to have even more success along those 2 lines. The retinal prosthesis, Argus, we've done probably about 15 of them at the Cleveland Clinic. They stopped making it. I think the results have been a little bit disappointing. And evidently prenatal diagnosis is available for those families that decide to have it. So to conclude here, I would say that a classification of childhood retinal dystrophies remains in evolution as we are refining phenotype, genotype correlations. But the tendency is for us to refer to these diseases by their gene names as much as possible, to teach about them, to to clinicians and to patients and so on. Actually, the patients have adopted the genetic classification probably better than the ophthalmologists, and we need to probably use a combination of both. We know so much more about the natural history and the clinical manifestations, especially with the advent of better diagnostic instruments, and these imaging techniques and technologies allows an easier clinical diagnosis, and our ability to send a sample and have either the whole exome or genome sequenced, or a panel of 800 genes that cause retinal dystrophies and associated systemic diseases tested well, have made a precision diagnosis available, I would say, in a good 75–80% of cases. And this evidently leads to better counseling and better matching of patients with clinical trials and emerging therapies. So I will end with this slide here. There is really hope. I wouldn't say at the horizon, it's here, and we are delighted to see it. So I thank you for your attention, and I'm happy to take questions as needed.
Thank you, Elias. Whoops. Najmin. By the way, he painted that last slide. It's beautiful, Elias. I love it.
Thank you.
Thank you for this wonderful lecture. This is a real tour de force. Do we have time for questions?
We have a couple minutes, sure. Yeah.
Are there any questions for Dr. Trabulsi?
I have a quick question that caught my eye. In your slide about investigations, you mentioned something about, and you may have answered it, but I didn't quite follow. You said something about you use adaptive optics. What did you mean by that?
So I don't use it here, but adaptive optics is an imaging technology that allows the visualization of individual photoreceptors. The way it is now, it can only catch, it was developed in labs first, where the setting, just to be able to do it, costs millions of dollars. It's a humongous setup of a multitude of prisms and lenses that direct laser lights to the photoreceptor layer, and they can image maybe at 3x3 millimeter, and the patient has to be steady for a long time to capture. Now, it has been commercialized, and there is a company I think in France that makes a camera for adaptive optics. So it's one way that does not help us in diagnosis as much as it helps us follow these patients if they are the recipients of treatments. Because that part remains one of the major challenges in these gene therapy trials. What are we following up? What are we measuring? How can we tell that a treatment works? Visual acuity, visual fields, adaptive optics. There's a bunch of ERG, etc. There's a number of technologies and a number of parameters that could be measured. And adaptive optics, because you can count the cells, you can see how many, you can hit the same area and repeat it. So that's what it is. It's some places would have it available, but I suspect that it's still only being used on a research basis.
Thank you. There's some questions in the chat, Elias. One question is which supplement or antioxidant do you recommend to patients?
Good question. I honestly, I don't know that any of them really makes a difference despite the studies that have been published. So I have a handout that lists them, the vitamin A and the others. And I give it to the patient. I tell them, this is not going to hurt you if unless you have liver disease, evidently. Uh, and if you want to take it, you can. And if you don't, I don't know that you're doing yourself any disfavor. So I'm not very anxious about those. I don't know how your Toronto group feels, but
Well, I tend to recommend antioxidants, and if there's a maculopathy, I'll recommend lutein or zeaxanthin just to.
yeah, I mean, there certainly is no harm at all from any of them, and most patients would take you up on it, but I don't have them leave the office thinking that they absolutely have to take them.
No, question.
Yeah.
There's another question. Is sensitivity to light is an indicator of cone dystrophy? Are problems with glare also a good indicator, or is this too non-specific?
Yeah, glare is non-specific. The patients who have cone dystrophy would either it's severe, like in some achromats, where they cannot even open their eyes in a room with normal lighting. They keep them shut until you turn the lights off, and then they can open their eyes. When they go outside, they have to put 2 pairs of sunglasses on top of each other. And in fact, in some of these patients, there's a special kind of brownish, reddish filter or to the glasses that could be applied. There's a number for it that they feel comfortable with. So Dick Lewis would call this photodysphoria instead of photophobia, but it really hurts them. The other question that one can ask, and I think I mentioned it, you ask them if they are more comfortable in dim light or in bright lights when it's not severe light sensitivity. And patients with Stargardt disease will tell you that they prefer the lights to be dim, actually, early, at least early in the course of their disease. As they progress and they start losing their rods and they become more of a cone rod dystrophy like patients, some of them do and some of them don't, then even in dim lights they can't see well. But yes, I would say glare is not a good one, just like driving at an inability to drive at night is not a good one for nyctalopia. So and in most patients would answer the questions having in mind glare or having in mind driving, when in fact you have to redirect them and ask them the question again to make sure that you're asking about dark adaptation and you're asking about really photodysphoria. And that would help clarify the category of diseases you want to put them in.
Thank you. Yeah, I use photoaversion.
Photoaversion is actually dysphoria is more associated with pain. Here they want to avoid the light. I think that's even a better term, Elise.
Thank you.
Thanks.
You can quote me on that.
I will.
Not Dick Lewis, me. Well, on this, Elias, it's so great to see you first.
Thank you.
I really want to thank you for this wonderful lecture.
Thank you.
And I look forward to seeing you at Jack Crawford Day in 20 minutes. And I'll turn this back on to John and Amandeep.
Yes, thank you very much again for sharing your insights into this field, which you've done a good job in continuing to help us make it less confusing. I still wish they would name the genes after the conditions, but I understand that even that it is not so simple as that. So, so thank you very much for taking us through not only what you do to diagnose them, but the moves forward in helping to help these patients. So please stay tuned for Jack Crawford, and next week, Grand Rounds, we're going to continue on the retina theme with Dr. Curtis and resident presentations in the usual format. Don't forget to fill out the evaluation form that Amandeep put in the chat box.
All right. Have a good Friday, everyone.
Thank you,
Enjoy
guys.
Rock
See you
Crawford.
later. Bye-bye.
Thank you very
Thank
much.
you.